Thank you very much, Dr. Marudan, for your kind words of introduction. Good afternoon to all of you, ladies and gentlemen. Today I'm going to discuss about the management of heart across the ejection fraction spectrum and new updates. So, what is heart failure? Actually, the general population would recognize it as the failing or dysfunction in heart. But when it comes to the medical terms, understanding is usually the failure of or the dysfunction of the ventricle. So, over last decades, several classifications, definitions, as well as the categorizations came out. However, finally, the latest definition of classification classifies different phenotypes according to the left ventricular ejection fraction. So today my aim is to take you across this new classification. And now, according to the new universal definition, we have three main categories. So that is depending on the left ventricular ejection fraction. The main three categories are heart failure with reduced ejection fraction, and that is the ejection fraction less than 40%, and the heart failure with mildly reduced ejection fraction, that is the EF in between 41 to 49%, and the third one is the heart failure with preserved ejection fraction. That is when the ejection fraction is more than 50%. So now, in addition to that, the NYHA functional class assessment, which has been there from good olden days, are still existing, and that is based on the severity of symptoms and the physical activity. As you all know, the class 1 is no limitation of physical activity, and class 2 is light limitation of physical activity, and class 3 is marked limitation of physical activity, and class 4 is unable to carry out on physical activity without discomfort. Now, again, the ACC-HA staging system is also existing still, and according to that, this classification mainly stages the heart depending on the, to evaluate the development and progression of the disease. And the NYHA classes focus on exercise capacity and the symptomatic status of the disease, but this one, the ACC-HA staging, will mainly focus on the to evaluate the development and progression of the disease. Now, this is just to highlight you, and this is just to show you that there are millions of people are living with heart failure across the globe, and annually billions of money spent on them directly as well as indirectly. Now, we are directly moving into the heart failure with reduced ejection fraction management. Now, we all know the classification is that ejection fraction is less than 40%. Now, the diagnosis will basically depend on having the target ejection fraction of less than 40%, together with symptoms plus or minus signs of heart failure. Now, when it comes to the management of heart failure with reduced ejection fraction, we have 4 basic weapons. So, they are the mineralocorticoid antagonist, beta blockers, SGL2 inhibitors, as well as the ARNI, that is the angiotensin receptor neprilysin inhibitors. And when this ARNI is, when the settings are not favorable to start ARNI, we would go for the ACE inhibitors. So we'll move into this drug management. Now, when it comes to these 4 foundation drugs, all these drugs, the mechanism of action are independent and additive. We do have several other drugs. We will be dealing with them in later. Now, when it comes to this, now to the ESC 2021 guideline recommendation, all our 4 drugs are there in which carries the class 1 recommendation. And you all know that an ACE inhibitor is recommended for patients with heart failure with reduced ejection fraction to reduce the risk of heart failure, hospitalization, and death. And we all know that the consensus and the SOLVIT trials that we had in initial phase, they have which was done with enalapril, has proven the mortality as well as morbidity benefits. And in addition to that, the number 2, this beta blocker is recommended for is recommended for the patient with stable heart failure to reduce the risk of heart failure, hospitalization, and death. Once again, it is also class 1A indication. And once again, we have these our all trials and the studies. Those are the Copernicus, CBIS-2 trial, as well as MERIT trial, and it stands for class 1A indication. And the mineralocorticoid receptor antagonist is recommended for the patients with heart failure. Once again, that is always. Now, this is also to reduce the risk of heart failure, hospitalization, and death. That is also goes as class 1 indication. And this dapagliflozin or the empagliflozin, that is the SGLT2 inhibitors, also now we recommended them for to use as class 1A indication to reduce the risk of hospitalization and cardiovascular death. So I will be dealing with these drugs later. And now when it comes to sacubitril valsartan, it is recommended as a replacement for ACE inhibitors in patients with heart failure with reduced ejection fraction to reduce the risk of heart failure, hospitalization, and death. Once again, it is class 1A indication, but level of evidence B. Now, when it comes, now we all know that the ACE inhibitors, and when it comes to the sacubitril valsartan, this ARNI, that is the angiotensin receptor neprilysin inhibitor, the major trial which was carried out to compare the ACE inhibitors and this ARNI, that was the Paradigm Heart Failure trial. In the Paradigm Heart Failure trial, it was proven that sacubitril valsartan is superior to enalapril in reducing the all-cause mortality, hospitalization from heart failure, as well as the CV, cardiovascular mortality. So because of that, it was recommended that ACE inhibitors or the ARBs is replaced by this drug in ambulatory patients with heart failure with reduced ejection fraction. Who is having symptoms despite the maximum optimal medical management. But anyway, the washout period of 36 hours is needed in order to avoid the bad angioedema. However, the Paradise trial, the results of the Paradise trial was released in last year. Actually, it was mainly done to compare the sacubitril valsartan with the ramipil, that is mainly to determine the superiority in reducing the heart failure events following MI. Even though the favorable observations are there for ramipril, at the moment, still more supportive informations are there to continue already existing guidelines to replace it. And then we are moving into the other drugs. We have several other drugs like ivabradine, digoxin, hydrolyzine nitrate combination, loop diuretics, and the Vasuquat, that is the soluble guanylate cyclase receptor stimulator, as well as the omecamtiv. These are the newer generation drugs, as well as ferric carboxylates. So now, if you go back to the previous slides, you will realize that our all major drugs, they are to reduce the risk of heart failure, hospitalization, and death. And when it comes to the other drugs, now this is the loop diuretics. These diuretics are recommended in patients with heart failure with reduced ejection fraction with signs and symptoms of congestion. This is to alleviate the heart failure symptoms and as well as to improve the exercise capacity and to reduce the heart failure hospitalizations. And there's no mortality benefit from this loop diuretics. And when we go to this ivabradine should be considered in patients only with who are in sinus rhythm. And when this in sinus rhythm and the resting heart rate is more than 70 beats per minute, despite treatment with an evidence-based dose of beta blocker or maximum tolerated dose below that, to reduce the risk of heart failure, hospitalization, and cardiovascular death. And anyway, the ivabradine should be considered in symptomatic patients with left ventricular ejection fraction less than 35 in sinus rhythm and a resting heart rate more than 70 who are unable to tolerate or have contraindications for beta blockers, that is to reduce the risk of heart failure, hospitalization, and cardiovascular death. Now, this soluble guanylate cyclase receptor stimulator that may be considered in patients with NYHA class 2 to 4 who have had worsening heart failure despite treatment with ACE inhibitor or a beta blocker and mineralocorticoid receptor. That is our optimal medications therapy. So this one, now the recent studies, that is the Victoria study, so it has revealed that it will reduce the incidence of primary endpoints of death from the cardiovascular risk as well as the hospitalization from heart failure. But anyway, it has not shown to reduce the all-cause mortality of all-cause mortality. So because of that, at the moment, this is it stands as 2B indication. And this hydralazine and isosorbide nitrate combination, actually a small study was done on black patients. So once again, it stands as 2A indication for the patients with heart failure with reduced ejection fraction. And when it comes to the digoxin, now digoxin, we have been using this drug over many years, but anyway, the DIGE trial has neutral effects on overall mortality. So the digoxin may be considered in patients with symptomatic heart failure with reduced ejection fraction in sinus rhythm despite treatment with ACE inhibitors, a beta blocker, and mRNA to reduce the risk of hospitalization. But anyway, the use in symptomatic heart failure with AF and rapid ventricular rate when the other options are limited. So that is the main indication that we are using the digoxin. Now, when it comes to this all drugs, now in the initial phase of this 4-drug concept, they have introduced this sequential introduction of drugs. So according to the initial phase, now the step 1, they say that to go for the beta blockers plus SGLT2 inhibitors. Now, the reason behind that is the beta blocker generally, it most effective for risk of sudden cardiac death, so it goes as the step 1. And then at the same time, SGLT2 have striking early benefits for hospitalization for heart failure, and it will also reduce the short-term risk of worsening heart failure with beta blockers. And then when it comes to step 2, addition of ARNI within 1 to 2 weeks of step 1. So that is OI, the angiotensin receptor blocker, or if the systolic blood pressure is less than 100 mercury millimeter, we have to evaluate the tolerance before adding these drugs. And but anyway, the risk resolves with repeated dosing or adjusting the diuretic dose. Now, step 3 is addition of mineralocorticoid receptor antagonist. That is within 1 to 2 weeks of step 2 if the serum potassium is normal, as well as if the renal function not severely impaired. So now the favorable effects of SGLT2 and ARNI to improve renal function and potassium homeostasis may increase the tolerability of this mineralocorticoid receptor antagonist. And most important thing is that all 3 steps achieved within 4 weeks and the uptitration to target doses thereafter. And even though we have this rapid sequencing, is it really necessary? Now, the efficacy of each foundation drug class is independent of treatment with the other drug class. So, the historical sequencing is not mandatory. And the background therapy can influence the tolerability of the other foundation agent. So, the proper sequencing should account for better combination therapy. Low starting dose of foundation drugs have meaningful therapeutic benefits, and broad-based coverage should be prioritized before uptitration. Mortality and morbidity benefits evident within 4 weeks of initiation of therapy. Now, because of that, now from this ACC 2020 guidelines, they have asked us to go for, tailor-made approach rather than going by the sequential approach. Now, in addition to that, now we have given this drug management. We have to understand, we have to understand that another pathway for the management is also existing. Now, if the patient is having left ventricular ejection fraction less than 30%, 35%, there are indications for ICD implantation and the non-ischemic as well as the ischemic. I will be discussing this at the end of my presentation. And also there is a place for CRT therapy, especially if the patient is in sinus rhythm with the left ventricular ejection fraction less than 35% and the QRS duration is more than 130 milliseconds. Now we'll move into the heart failure with mild reduced ejection fraction. That is the ejection fraction in between 41 to 49% category. Now this ESC guideline recommendations to diagnose, actually, we have to have the presence of symptoms and signs of heart failure and mild reduced ejection fraction and the presence of elevated BNPs. So those are the, the supportory the criteria. And also there should be other evidences of structural heart disease, that is like increased left atrial size, LVHO echocardiographic measurement of left atrial filling. So the presence of these evidences make the diagnosis more likely. So, and what is the most important part of recognizing this as a major category? That is because the heart failure with mild reduced ejection fraction may benefit from similar therapies to those with low left ventricular ejection fraction. This support the renaming of heart failure with mid-range ejection fraction to heart failure with mild reduced ejection fraction. Now, when we go to the recommendations, the ESC 2020 guideline recommendation that we have the patients with, all the class 1 recommendations that we use for the patients with heart failure with reduced ejection fraction is there, but when here it is most of them are in class 2B. So the class 1 indications are the diuretics. They are recommended in patients with congestion and in order to alleviate the symptoms and signs. All the ACE inhibitors, ARBs, beta blockers, mineralocorticoid receptor antagonists, as well as sacubitril valsartan, they all come under class 2B indications. Now we'll move into the heart failure with preserved ejection fraction. That is when the ejection patient is having the symptoms and signs of heart failure and the left ventricular ejection fraction is more than 50. Once again, we should have the it's easy for us if we are having the objective evidence of cardiac structural or functional abnormalities consistent with the presence of left ventricular diastolic dysfunction as well as raised left ventricular filling pressure and also the raised BNPs. Now, the patients with the history of overtly reduced left ventricular ejection fraction that was less than 40%, who later present with left ventricular ejection fraction more than 50%, should be considered to have recovered from heart failure with reduced ejection fraction. Right? So heart failure with improved left ventricular ejection fraction rather than heart failure with preserved ejection fraction. So in these patients, continuation of the treatment for heart failure with reduced ejection fraction is recommended. Now, when we come to the management of heart failure with preserved ejection fraction, if we go through all these trials, now the various agents over the year have failed to demonstrate benefit on hard outcomes in the management of heart failure with preserved ejection fraction. Anyway, now the recent trials that empagliflozin, the Emperor Preserve trial, has anyway shown that is the first as well as the only agent to demonstrate benefit in patients with heart failure with preserved ejection fraction with or without diabetes with consistent benefits in patients with or without diabetes. So because of this reason, I just thought of discussing these SGLT2 inhibitors in heart failure, in the management of heart failure. Now the sodium glucose co-transporter inhibitors, the rationale for exploiting this molecule is that diabetes and heart failure have the similar pathophysiological features. So they have the endothelial dysfunction as well as they have insulin resistance. In addition to that, the mechanistic effects of SGLT2 inhibitors are seen in patients with and without diabetics. So they have better diuretic effects as well as better metabolic effects. And the cardiovascular benefits of SGLT2 inhibitors are largely independent of glucose levels. Now, the indirect actions of SGLT2 inhibitors in cardiac function. Now, you all know these SGLT2 inhibitors acts through the kidney, and it will have favorable effects on glycosuria, and it will have favorable effects of natriuresis as well as diuresis. And because of that, the heart will have favorable hemodynamic effects by reducing the systolic blood pressure, reducing arterial stiffness, as well as by reducing plasma volume. And also the favorable metabolic effects will cause, to heart to have the protective action against the heart failure, that is by reducing the body weight and reducing the hyperglycemic state as well as by reducing the glucose toxicity. And in addition to that, these SGLT2 inhibitors will have the effect on afferent arterioles, so it will increase the release of erythropoietin, which in turn regulate the circulating progenitor cells as well as inflammatory cells, and which in turn will have favorable effects on heart, and it will increase the oxygen delivery as well as to reduce the left ventricular mass. Now, we have direct as well as indirect actions of SGLT2 inhibitors into the heart. We have discussed the indirect actions more now, and we'll now move into the direct actions. Now, heart, because of this molecule, it will cause the, improve the endothelial function of the heart, because, and it will also improve the myocardial autophagy, and as well as it will inhibit the cardiac fibrosis. Now, because of all these effects, finally, due to the indirect effects on indirect effects as well as the direct effects on heart, finally the SGLT2 inhibitors decrease the severity of heart failure. Now, when it comes to the heart failure therapies having the diuretic effects. Now, when we go through this, the adverse effects, if we compare mineralocorticoid receptor antagonists, loop diuretics, SGLT2 inhibitors, thiazides, and acetaminophen, you will realize that with the SGLT2 inhibitors, the incidence of hyperkalemia, hypokalemia, and all these electrolyte disturbances will be minimal. And in addition to that, SGLT2 inhibitor, it's once daily dosing, and it's a single dose one, and titration of dose is also not needed. So, do we have trial evidence to, prove these actions? Now, when it comes to the Emperor-reduced trial, that is mainly done to assess the efficacy of this molecule in heart failure with reduced ejection fraction. So, they have done it with the empagliflozin 10 milligrams. So, they have the confirmatory endpoints, and as well as this, the confirmatory endpoints were the composite primary endpoints as well as the secondary endpoints. Now, when we got to the primary endpoints, now this with the empagliflozin, it reduces the cardiovascular death or hospitalization for heart failure, and you will realize it has a significant p-value. And then when it comes to the total hospitalization for heart failure, once again the empagliflozin arm is favorable. So once again it has the significant p-value. And the key secondary endpoints, so the empagliflozin protected the kidney by slowing the progression of kidney disease. And once again, this p-value is significant. So now, this from this Emperor-reduced trial, we have the confirmatory evidence of efficacy of this molecule in heart failure with reduced ejection fraction. So, when we take all the primary endpoints, key secondary endpoints, and the eGFR slope, all confirmatory evidences are there. And in addition to that, the empagliflozin also reduced the composite renal endpoint, that is the end-stage kidney disease, so sustained profound decrease in eGFR. And And also, the clinical benefits of all-cause mortality or worsening heart failure was evident from day 12 onwards. If you just compare these charts, you will realize this arm, it has the evidence from day 12 onwards. So, these SGLT2 inhibitors in heart failure with reduced ejection fraction. Now, even though the SGLT2 inhibitors used to be a type 2 diabetic management drug, now guidelines recommend it in the management of heart failure with reduced ejection fraction. It requires single dose once a day without titration. So, in patients with heart failure with reduced ejection fraction, empagliflozin significantly reduced the risk of cardiovascular death or hospitalization by 25% versus placebo in patients with or without diabetes. Now, and it also reduces the total hospitalization for heart failure, and also it reduces the composite renal outcome by 50%. And when it comes to the heart failure with preserved ejection fraction, we do have our trial evidence to show that it is beneficial. Now, the Emperor Preserved trial, that is once again done with the empagliflozin. So, 2/3 of these patients in Emperor Preserved trial has the left ventricular ejection fraction more than 50%, because you know that to begin with they had the LV ejection fraction more than 40%. Anyway, later after the analysis they have found out that the 2/3 of the patients were having the LVEF more than 50%. So the data are validated for this entity, and the both components of the primary endpoints, cardiovascular death and heart failure hospitalization, contributed to the beneficial effects. Now, if we take this graph, you will realize that it has the 21% relative reduction in the composite primary endpoints of cardiovascular death or the heart failure, so with the significant p-value. And then it also has the confirmatory secondary endpoint, reduce the first-time recurrence of hospitalization by 20%, once again with significant p-values. So, and it also protects the kidney by significantly slowing the decline in kidney function. So when it comes to the Emperor Preserved trial, once again, the specific endpoints that we have the confirmatory evidences to say that it is effective, and all the primary endpoints, key secondary endpoints were met. And now, even though we have the evidence, still it is not there in the guidelines, but if approved for the treatment of heart failure with preserved ejection fraction, empagliflozin would change the clinical practice in the management of heart failure with preserved ejection fraction. Now, in addition to that, I would like to touch on this device management a little bit, because we know now when we in the management of heart failure with reduced ejection fraction, there is the place for ICD implantation as well as the place for CRT devices. Now, according to the latest ESC recommendation, the ICD, this is the implantable cardioverter defibrillator, that is the ICD, we use it as a secondary prevention, and this ICD is recommended to reduce the risk of sudden death and all-cause mortality in patients who have recovered from ventricular arrhythmia causing hemodynamic instability. So this goes as class 1A indication. And when it comes to the primary prevention, that is that ICDs recommend to reduce the risk of sudden death and all-cause mortality in patients with symptomatic heart failure of an ischemic etiology, unless they have had MI in the prior 40 days and left ventricular ejection fraction less than 35%, despite more than 3 months of maximum therapy, provided they are expected to survive substantially longer than 1 year. So this is once again 1A indication. So when it comes to the primary prevention, this 2A indication is, newly introduced into the guideline. So there are, and ICD should be considered to reduce the risk of sudden death. That is for the non-ischemic etiology as well, because in the previous slide, if we go back, you will realize that this is for the ischemic etiology. So now for the ischemic etiology, ICD has got class 1A indication, and with the introduction of new guidelines for the non-ischemic etiology also, it has a place with 2A indications. And anyway, the ICD implantation is not recommended within 40 days of MI, as implantation at this time does not improve the prognosis. And now we'll move into the, this cardiac resynchronization therapy. So the cardiac resynchronization is recommended for symptomatic patients with heart failure in sinus rhythm. When the QRS duration is more than 150 milliseconds and the LBBB QRS morphology, and with the LVEF less than 35% despite maximum maximum medications in order to improve the symptoms and reduce the morbidity and mortality. So it goes as class 1A indication. And anyway, now once again, this was introduced into guideline, latest guideline. So patients with the CRT should be considered for symptomatic patients with heart failure in sinus rhythm with a QRS duration of 130 to 149 milliseconds with LBB morphology and with LVEF less than 35%. And this goes as class 2A indication. And now this anyway, the CRT rather than RV pacing is recommended for the patients with heart failure with reduced ejection fraction regardless of NYHA class. So this goes as class 1A indication. And anyway, CRT is not recommended in patients with QRS duration less than 130 milliseconds who do not have an indication for pacing due to high degree AV block. So then we'll move into the, the key changes to the heart failure in reduced ejection fraction treatment in 2021. And the new class 1 recommended therapy for heart failure with reduced ejection fraction is the SGLT2 inhibitors, dapagliflozin and empagliflozin. The 4 key drug therapies should be initiated as quickly and safely as possible. And the importance of tailor-made management rather than, the sequencing management was highlighted. And the primary prevention ICD in non-ischemic cardiomyopathy is now comes into class 2A indication, and the emphasis on broad LBBP in selecting patients for CRT we have just discussed. Thank you.